Welcome to another episode of Clot Conversations from Thrombosis Canada. I'm David Airdrie, Executive Director.
And I'm Jamil Abdul-Rahman, hematologist from Toronto General Hospital.
We're here to provide you with updates on diagnosis and management of thrombosis, featuring interviews with authors of recent research publications and highlights of education programs from Thrombosis Canada. Thank you for joining us for this episode.
In this episode, we will be discussing a recent paper published in Chest entitled Perioperative Management of Antithrombotic Therapy, an American College of Chest Physicians clinical practice guideline with lead author Dr. Jim Douketis. Dr. Douketis is a staff physician in general internal medicine and clinical thromboembolism at St. Joe's Healthcare in Hamilton. He is a professor of medicine and holds the David Braley-Nancy Gordon Chair in Thromboembolic Disease at McMaster University. Dr. Douketis is a past president of Thrombosis Canada. Dr. Douketis' research interests include perioperative antithrombotic therapy, prognosis of patients with venous thromboembolism, hormonal therapy and thrombosis, prevention of venous thrombosis in medical patients, and clinical practice guideline development. Dr. Douketis is a fellow of the Canadian Academy of Health Sciences, past president of Thrombosis Canada, associate editor of McMaster Textbook of Internal Medicine, editor-in-chief of Canadian Journal of General Internal Medicine, deputy editor of Annals of Internal Medicine ACP Journal Club, and associate editor of Thrombosis and Haemostasis. He has over 350 peer-reviewed publications. Thank you for joining us again today.
It's my pleasure, Jamil.
Great. So with the guidelines, there are 44 guideline recommendations in there. So maybe we could go through just a few of them. So there's a couple that have strong recommendations. The first one is about heparin bridging in patients with atrial fibrillation. Could you tell us about that?
Sure, and maybe I can preface that question by just mentioning that these guidelines offer new advice and guidance for patients who are receiving direct oral anticoagulants or DOACs. It also talks about perioperative laboratory management, and these are areas that were not covered in previous iterations of this guideline, or in fact haven't been covered in other guidelines. So I think they'll be very helpful to clinicians to kind of broaden the scope of the topics. But to your point about our strong recommendation looking at patients who have atrial fibrillation and are receiving a vitamin K antagonist, typically warfarin, we do provide in this case a strong recommendation against the use of heparin bridging, and that's typically with a low molecular weight heparin pre and post-operatively. And the basis for that is anchored on the BRIDGE trial, which was published actually 7 years ago in the New England Medical Journal, that did not show any benefit of perioperative heparin bridging pre and post-operatively in these patients, and in fact caused harm by increasing the risk for major bleeding by threefold. So this study, coupled with other observational studies that have not shown benefit of heparin bridging, but likewise have shown harm, led us to provide a strong recommendation against the use of heparin bridging in warfarin-treated or VKA-treated patients with atrial fibrillation.
Okay, but there still is a subgroup of patients with atrial fibrillation who are deemed higher risk, who we think might benefit from bridging. Who is that group that might benefit?
Now, one of the things that's I think very helpful with these guidelines, Jamil, is that we provide recommendations, but also we provide some qualifying remarks associated with most of the recommendations. And in this case, you're absolutely right. I mean, there may be a patient with atrial fibrillation who might have had a previous stroke or systemic embolism during an interruption of warfarin before, or there may be a patient who has a CHADS-VAS score of 9 or a CHADS score of 6, where a clinician may be concerned about having a perioperative stroke, especially if within that score they've had a previous stroke. So I think there needs to be some flexibility with these guidelines. They're not meant to encompass every single patient. And yes, of course, there are situations in atrial fibrillation where heparin bridging may be reasonable. And we address that because there are situations where the risk itself may be different than kind of the average risk which the guideline pertains to.
Right. And there's also another strong recommendation regarding perioperative VKA in patients having a pacemaker or ICD. Can you tell us about that guidance?
Yes, now the cardiologists have really led the field in this area by undertaking a number of randomized controlled trials that have compared continuation of anticoagulation with warfarin and in some cases with direct oral anticoagulants versus what was considered the standard of care approach of interruption of anticoagulation and administration of perioperative bridging, in this case with cardiac device procedures, typically a pacemaker, but also an ICD. And what this evidence found that continuing the anticoagulant, usually in this case warfarin, was actually safer than stopping it and administering heparin bridging. So based on this fairly high quality evidence, this provided us with the basis to give a strong recommendation to continue anticoagulation in those patients who needed a cardiac device. Of course, as before, there are some caveats, and one of them would be that you would want that INR to be less than 3 at the time of the procedure. So this is an area that's advanced a lot. And of course, as our population ages and these technologies are becoming more available, we're seeing more and more of these patients. So it's timely, but also very relevant to everyday practice.
Great. One area that I always find is tricky is perioperative bridging for patients with mechanical heart valves. So that's addressed in statement 5. So I'm glad that's in there. So right now it's a very low certainty of evidence, but the guidance suggests against heparin bridging in those with mechanical heart valves who require VKA interruption for an elective surgery or procedure. Could you speak to the evidence that went into the statement?
Sure. And first of all, this is a conditional recommendation, so it is based on lower quality evidence, and it allows clinicians flexibility to follow or not follow the guidance. And the rationale for providing a conditional recommendation against heparin bridging in patients with mechanical heart valves on warfarin, of course, who need interruption for a surgery was anchored on the Periop 2 trial, which included patients with a mechanical heart valve who needed a surgery or procedure and interruption. But of course, with this trial, all patients received pre-operative heparin bridging and then were randomized to a bridging or no bridging strategy post-operatively. So that has to be taken into consideration. So in that study, there was no benefit in terms of preventing thromboembolism with the administration of heparin bridging. And the rates of thromboembolism, including stroke, as well as the rates of bleeding, were actually quite low in both the bridging group and the no bridging group. So that study, coupled with observational data, which showed that in patients with a mechanical heart valve who were not bridged as compared to those who were bridged, again, not randomized comparisons, showed no difference in outcomes with that totality of data, but with some limitations, we provided the basis for a conditional recommendation against bridging in patients with mechanical heart valves.
Right, and I think in the guidance you mentioned a meta-analysis of non-randomized studies, which did show an increase in bleeding with bridging. Is that correct?
Yes, and I think when we look at the totality of evidence across all clinical indications for atrial fibrillation or mechanical heart valves and even venous thromboembolism, I mean, I think there's a consistent message that has emerged over the past 10 years that administration of heparin bridging is risky and tricky in the perioperative setting. And there's consistent evidence that it causes rates of major bleeding anywhere between 3 and 8%, depending on the studies. And these are quite important because they occur in a vulnerable population who may have a surgical wound. They might be at home past their surgery. And the other part of what the guidelines do is that they say, okay, we acknowledge that we don't want to be bridging patients, most of them with atrial fibrillation, some of them with a mechanical heart valve. But Jamil, as we said a few minutes ago, there may be situations where, you do want to bridge. There may be a compelling clinical reason. So what the guidelines actually also do is they provide a kind of how-to stepwise approach to bridge patients. So if you are going to do it, you'll do it in a manner that is safe, that minimizes the risk for perioperative bleeding and the downstream consequence of minimizing delaying anticoagulation perioperatively, which we don't want to do because it'll increase the risk for those thromboembolic events that we want to prevent in the first place.
Perfect. Okay, great. Moving on to DOACs, the guideline also goes through content on DOACs as well. Is the guidance in keeping with the PAUSE study? Do we need to change the thrombosis calculator, the Thrombosis Canada perioperative calculator? What are the new suggestions or recommendations that we should be aware of regarding perioperative DOAC use?
And this is an area, as I mentioned earlier, that is new from previous iterations of these guidelines, and other groups have not really covered this extensively. But DOACs, as we know, are the dominant anticoagulant in clinical practice. So these are being seen exceedingly frequently nowadays. And what the recommendations provide here, and they are conditional recommendations because there are no randomized trial-based data, but multiple observational study data that provide a path, a roadmap to interrupt and resume DOACs perioperatively, anchored on patients' bleeding risk, which is associated with the procedure. So either a low, moderate bleed risk, you'd be off your DOAC for 1 day before and the day of the procedure. And if you're at high risk, and this includes any kind of neuraxial procedure, by the way, you'd be off the DOAC for 2 days before and then 2 days after. So 2 days off if you're low moderate risk, 4 days off if you're high risk. And the only exception to that is a minority of patients on dabigatran who have impaired renal function, and they get a longer interruption because of the renal clearance of dabigatran. So this is, I think, an important addition to the guidelines and clinical guidance. And yes, these are completely aligned with the tools and the guidance that's provided in the Thrombosis Canada website. So in a sense, Thrombosis Canada was a bit of ahead of the curve, if you will, in terms of incorporating evidence from the PAUSE study and related studies. And now we've picked them up with the ACCP guidelines. So once again, the Thrombosis Canada guidelines for the DOACs remains essentially the same. And to me, and to others, it's a valuable resource for healthcare professionals.
Thanks so much. Great. And lastly, I just want to also draw attention. There's some really helpful tables in the guideline. There's table 1. We talked before about those high-risk patients. So table 1 kind of divides high risk, medium risk, low risk. So that was quite helpful. And there's also table 2, which categorizes surgeries and procedures by bleeding risk. As a non-surgeon, I don't really know the bleeding risk of these procedures, so I found that to be very helpful.
Well, our view is that a picture is worth 1,000 words, and there are 2 key tables, as you say, as part of these guidelines, which provide an empiric classification of thromboembolic risk and an empiric classification of procedure surgery associated bleeding risk. And then we have some figures accompanying the guidelines that provide visual representations of how to manage patients on warfarin who need bridging, how to manage patients who are on a DOAC, and how to manage patients who are on an antiplatelet drug or more than one drugs. So if somebody wants to just zero in on those key things, that would covers a lot of the evidence and a lot of the material from the guidelines. But the the approach, though, as you alluded to, Jamil, is that when you have a patient in your clinic who's on an anticoagulant, I think the first thing I do is say, okay, what is their risk for bleeding associated with the procedure? Because if the risk is very low, or what we call minimal, then I don't really have to worry about interrupting the anticoagulant. Maybe I might just delay the dose on the day of the procedure until after the procedure. So that's step one for me. And then step two is I incorporate the thromboembolic risk, especially in patients on warfarin, because that will tell me whether I may need to consider bridging in those patients that are, by the classification, considered high risk for thromboembolism. So these are meant to be very practical and address, patients who are seen in a everyday practice by an array of healthcare professionals.
Thank you.
Thanks, Jim. We had a great discussion on the GI guidelines earlier this year. Can you discuss how those guidelines and these align?
Yeah, I think as everyone in the audience knows that different medical societies will produce guidelines, and in this case on perioperative management that is pertinent to their area. So we previously had a podcast on the Canadian Association of Gastroenterology, American Association joint guidelines on perioperative management of patients who required gastrointestinal procedures. So that sort of really drill down on a number of different procedures, and it would be most relevant for gastroenterologists that are doing those procedures. The ACCP guidelines takes a much broader view and doesn't really drill down too much on GI procedures, although we do talk about a little bit about colonoscopies and people requiring a polypectomy, which fall into the high bleed risk procedure category that you need to interrupt anticoagulation. And overall, the two guidelines I look at as being very complementary. If you want, one-stop shopping, go to the ACCP guidelines. If you want to drill down on GI procedures, go to the CAG, American Society of Gastroenterology guidelines. So they mean to complement each other.
That's great. Are there any other guideline statements that we've not discussed today that you'd like to bring up?
I think we've covered the main ones that, looking at bridging therapy with patients on warfarin, looking at DOAC therapy. We didn't touch too much on antiplatelet therapy. And I do want to point out that we came up with a conditional recommendation to continue ASA in patients undergoing non-cardiac surgery. There was some controversy and discussion around that, but I think the readers can look at how the data were interpreted. The area of perioperative antiplatelet management is one that does require additional research, especially among patients who have cardiac stents and are receiving dual antiplatelet therapy. But David, I think what I want to also finish off by saying and highlighting is that these guidelines are meant to be very practical. Yes, there's the methodologic rigor and that part of things, but they're also designed so that the practicing clinician can go through them and get some sensible advice. And so there's a lot of how-to sections in these guidelines that help with the everyday management. And of course, a lot of that how-to stuff is incorporated in the Thrombosis Canada clinical guides and tools. So in that way, we've looked to Thrombosis Canada to provide us with that practical model and inspiration. So I hope that readers can look at these guidelines, but be assured that all this material has been incorporated into the Thrombosis Canada perioperative guides and tools.
Well, that's terrific. I'm glad to know that we're all aligned and we can ensure that the listeners today can go to our site and see some of the things that you've just talked about. Thank you, Jim. Really appreciate you taking the time again to visit and have this discussion with us. And I want to thank our listeners for listening to Clot Conversations from Thrombosis Canada. We welcome your comments, questions, and suggestions on the podcast. If you have any recommendations for future podcasts, please send them to us at info@thrombosiscanada.ca. And please subscribe so that you are notified about the release of new episodes. And don't forget to check out our website for education programs, clinical tools, and guides. And also, please consider donating to Thrombosis Canada to support our ongoing efforts to reduce morbidity and mortality due to thrombosis. Have a good day.